Hello, I'm Dr. Brian Cole. I'd like to review with you the treatment of cartilage injuries and a little bit of what I've learned over the last 25 years. My disclosures are at the Academy website. So I think the first thing to take home is that these articular cartilage defects are quite common. We tend to see them at a higher frequency in our younger, more active patients. But in all comers less than the age of 40, we see them at an incidence of about 40%. What's critical to understand is they don't always matter. Many of these cartilage defects will never cause symptoms. Shelbourne has shown us that over 10 years, those who undergo ACL reconstruction who have a known cartilage defect tend to look no different after 10 years from those who actually did not have a cartilage defect at the time of their ACL surgery. We've learned over time that there's not a lot of evidence that suggests if someone is diagnosed with an articular cartilage problem in the knee, that activity levels will cause it to progress. And it leaves room for all of us to decide, can we undergo skillful neglect and watch these individuals to see if they might or could become symptomatic. Most of the treatment decision making is what I call nonlinear. We typically treat for the here and now. It's very important to ask patients what they really would like to see happen with treatment. We are taking a very thorough history, looking at previous surgeries, the response to that treatment, and pay close attention to concomitant pathology. I think the important thing that we've learned to understand is that there's no reliable correlation between their clinical symptoms and the articular cartilage status. But as I mentioned, this is an area that's ripe for skillful neglect. It is an option to treat these patients, and doing less rather than more has been taught to us by Lisa Rosenbaum and many, many others that, focusing on the MRI, focusing on the radiographs may not be the entire picture. We really tend to focus on patient symptoms and do they correlate with MRI and X-ray findings. Certainly, neglect can lead to increasing size of defects, like we've seen here in this high-level basketball player who, over a very short course of time, after having a very stable MRI, as the one on the left, demonstrated the increase in symptoms over the medial femoral condyle with the associated delamination occurred essentially at the same time. We know that defect size is important in this woman who had a 15 millimeter defect that underwent marrow stimulation. She failed to respond positively, and she underwent a 15 millimeter osteochondral allograft. The graph looks big, but that's because the surrounding area of normal cartilage surface area is quite small. So we've learned that those who have very small femoral condyles with relative similar sized defects tend to do less well initially and have worse pain scores on the in-go because they have less normal cartilage to shoulder the load. That's highly related to the fact that we think the bone actually matters most. We spend a lot of time on looking at ways to improve cartilage when the fact of the matter is that when patients present to us, it may have more to do with the bone than the articular cartilage surface. This is where we are today in the United States. We still perform debridement, but all the way through microfracture, somewhere in the neighborhood of 100,000 per year. We have allograft surface treatments, osteochondral autografts, cell-based transplantation, and osteochondral allografts. I recognize that outside the United States, we may not have all of those same options. The decision making has become really quite granular over time. We've divided into patients who have tibial-femoral versus patellofemoral lesions, and then we take into consideration comorbidities such as meniscal status and alignment, and then it boils down to defect size and whether or not it's a primary or revision treatment. Debridement is still one of the most basic treatments that we perform. It's a simple procedure with low resource intensity and may be ideal for smaller defects with the acute onset of mechanical symptoms, and may be important for staging arthroscopy. We noted that in patients underwent arthroscopic debridement in the setting of future cell transplantation, about 45% of them actually had symptom relief with a simple debridement. We think from our biomechanical work that it may have much to do with the fact that we can create vertical walls that help the normal cartilage better shoulder the load, letting the defect be less relevant. This is a case in point in a very young active individual who has a focal cartilage defect. He's actually an NBA player who had mechanical symptoms that were relatively acute onset. He underwent arthroscopic debridement, basically some debridement of the calcified layer to maybe promote some bleeding. We, after smoothing the surface, injected bone marrow concentrate, and he's continued to do well with just a very simple debridement procedure. We've become very interested in predicting who will do well with arthroscopic debridement versus who will move forward and look for early cartilage transplantation. We've shown that those with patellofemoral lesions who have low pain scores, and good physical exam component with a good MRI component actually can fare well and have a favorable outcome after simple arthroscopic debridement of their articular cartilage. In contrast, those with femoral lesions with high pain scores and low function with aggressive-looking MRIs tend not to do as well and need secondary transplantation. Marrow stimulation remains a low-cost option to return individuals to sport as long as the rehabilitation is adhered to. We typically perform drilling now rather than using a microfracture awl. These are typically smaller defects that can respond favorably to marrow stimulation, creating fibrocartilage fill. We've also shown that patients who undergo marrow stimulation will do better with drilling than the use of a microfracture awl, largely because of the subchondral response and the response to load that might occur early on. So we know that revision rates can be reduced if we drill versus using an awl. We've looked at a number of ways to improve marrow stimulation. Our most common way is the autologous minced cartilage or the autocar procedure, whereby we obtain articular cartilage using a shaver. It's minced, it's mixed typically with some type of orthobiologic, such as PRP or bone marrow concentrate, and it's placed directly into a lesion that's been prepared with or without marrow stimulation to create fibrocartilage repair tissue. Now, osteochondral autograft is still a main treatment and a dominant treatment strategy for small lesions, and especially in our higher level patients compared to marrow stimulation, but it's rare that we find defects that are small, say 10 to 11 millimeters in size. This is case in point. This is a basketball player who had a lateral femoral defect that had initial debridement, a little bit of tibial disease, failed to do well, and underwent a single plug osteochondral autograft. Cell transplantation still is an option in the United States, and we demonstrate high return to sports in the neighborhood of 75% as long as rehabilitation is adhered to. It can be used even for bipolar disease, osteochondral lesions. I typically use it for my younger patients with multifocal defects. The mainstay of my treatment for patients with articular cartilage disease is the use of an osteochondral allograft. We now have approximately 1,500 patients in our registry. This is a former NBA player who has a trochlear defect and a femoral condyle defect that was treated after a previous marrow stimulation. It can be used readily for the patella, typically in combination with tibial tubercle osteotomy, and can be size matched like we did in this NHL player for the trochlear. Our results have been quite favorable in the setting of osteochondral allograft transplantation with return to sport rates in the neighborhood of 75 to 88%. We've looked at a number of professional athletes who have undergone osteochondral allograft transplantation and demonstrated an 80% return to sport at the pre-injury level, and this is even in the setting of the potential concomitant meniscal transplant. We've looked at a number of basic science parameters to try to improve the outcomes of osteochondral allografts, including improving donor site matching, deep cleaning our grafts with compressed CO2 to eradicate marrow elements, adding bone marrow concentrate to improve integration, which we've demonstrated by CT scan, and have even tracked biomarkers with patients postoperatively to show that following osteochondral allografts, their biomarker profile tracks positively with their symptom reduction. As mentioned, these patients often have associated comorbidities such as malalignment, maybe ligament instability, and meniscal deficiency. Certainly, we know that post-meniscectomy syndrome is not that common, but it does happen, such as this woman who had a meniscectomy and within 6 months had progressive disease and underwent a meniscal allograft with an osteochondral allograft to treat her condition. Meniscal allograft transplantation performed either in isolation or with cartilage defects. We now have over 1,200 patients in our registry, demonstrate success rates with high return to sport in the neighborhood of 75 to 85%. Unfortunately, one of the things we've learned is that individuals who undergo meniscal allograft transplantation have about a 35% reoperation rate, but we've also learned that when they do undergo reoperation, there's a 65% chance that they will feel better after simple arthroscopy. Realignment procedures are sort of our what we call lowest hanging fruit. We've learned that patients can return back to high-level activities after osteotomy at a frequency of somewhere in the neighborhood of 70 to 90%. So this is a frequently combined operation at the time of cartilage repair. So how do I decide? I look at debridement in first-line treatment in in-season athletes who are lower demand, typically with mechanical symptoms. We still utilize marrow stimulation for smaller defects and often augment it with minced articular cartilage. The small defects that are 10 to 11 millimeters in size are very good for osteochondral autograft transplantation. Cell transplantation for our young multifocal defects with clean lesions that have not had previous surgery. And pretty much everyone else will receive osteochondral allograft transplantation, especially in the setting of meniscus transplantation. So some of the key takeaways are that we recommend treating the here and now rather than what might happen in the future. Very important to ask the right questions of our patients in terms of why they're there, what their goals are, what their expectations are. The decision-making we know is clearly not linear, and there are a number of variables that weigh into making decisions and managing patients with this problem. The load is probably one of the preemptive factors, and that's why osteotomy and other bone procedures are quite successful. We're really routinely looking at patient and organ-specific factors and looking to match the solution to our patient needs. It's very important to manage patient expectations and defining what success is, and we've learned that high-demand patients can achieve a satisfying result. We do well with activities of their living, but less well with the highest demand athletes. And finally, what we've learned over time is sometimes doing less, not more, is an adequate way to achieve a good or excellent outcome in terms of reducing pain and improving function. Thank you very much.